Hello, PsyQ and Nephew communities. Welcome to today's program, Major Depressive Disorder and Chronic Kidney Disease. Thank you for joining us. I am Dr. Jill Green, a medical science liaison with Otsuka Pharmaceutical Development and Commercialization, Inc. I'll be serving as your moderator and presenter for today's informative discussion featuring Dr. Chris Bojrab and Dr. Rima Kang. Chris Bojrab is a psychiatrist and has served as the president of Indiana Health Group since 2003. Dr. Bojrab is the team psychiatrist for the Indiana Pacers and serves as the psychiatric consultant to the Indianapolis Colts and Indianapolis Indians. He is active in organized medicine on a state and national level, having served as president of the Young Physician section of the Indiana State Medical Association, as well as holding offices in the American Medical Association and American Psychiatric Association. Dr. Bojrab graduated from Wabash College and then attended Indiana University School of Medicine, where he received his MD. He completed a 4-year residency in psychiatry at the Indiana University Medical Center, where he served as chief resident. Our other featured speaker today is Dr. Rima Kang, a nephrologist. She is an assistant professor of clinical medicine within the Division of Nephrology at The Ohio State University in Columbus, Ohio. Upon joining faculty at Ohio State, Dr. Kang has become the lead nephrologist in cystic kidney disease care and was instrumental in developing a specialty clinic at Ohio State with an emphasis in ADPKD and CKD care. Dr. Kang continues to advocate for improved patient care and is an active member in multiple associations and committees, including the National Kidney Foundation, or NKF, the Internal Medicine Quality and Patient Safety Committee, and the Internal Medicine Diversity and Inclusion Committee. Dr. Kang received her medical degree from Northeast Ohio Medical University and completed her residency in internal medicine at the University of Cincinnati Medical Center. Dr. Kang then went on to complete a distinguished fellowship in nephrology at the Ohio State University Wexner Medical Center.
Thank you, Jill, and welcome everybody to today's teleconference. I'm going to start us off with just a brief overview of major depressive disorder. And I think sometimes people, patients as well as clinicians, have questions about what constitutes a diagnosis of major depression and how is this separated from other feelings of sadness or grief and loss that patients may experience from time to time. So if we think in terms of diagnosis, major depressive disorder is comprised of persistent feelings of sadness and hopelessness, loss of interest in activities that they once enjoyed. Depression is the most common diagnosis seen by psychiatrists when seeing patients in the United States. It's a serious and chronic disabling illness affecting more than 350 million people worldwide. This has always been towards the top of the list of leading causes of disability worldwide. Historically has been the 4th leading cause of disability worldwide, but it's estimated that in 2020 it will move up to the 2nd leading cause of disability, really a reflection of the impact of this on individual patients, as well as the breadth of the illness and the length of time that it can affect patients over. There are also a number of residual symptoms that are quite common and can cause significant psychosocial, occupational, and other domain areas of functional impairment.
Next, I will discuss the stages of chronic kidney disease. Chronic kidney disease, according to the KDIGO guidelines, is defined as the presence of kidney damage that persists for 3 or more months. More so than just a definition by the glomerular filtration rate, there are other markers of kidney damage which also include albuminuria. So chronic kidney disease is subdivided into 5 stages according to the glomerular filtration rate. Stage 1 indicates kidney damage with normal kidney function, where the GFR is greater than or equal to 90. Stage 2 is kidney damage with mild loss in kidney function, where the GFR is 60 to 89 milliliters per minute. Stage 3 indicates mild to severe loss of kidney function, where the GFR is 30 to 59. And in fact, stage 3 is actually subdivided into stage 3A and stage 3B. Stage 4 indicates severe loss of kidney function, where the GFR is 15 to 29. And eventually, stage 5 indicates kidney failure, or ESRD, and stage renal disease, where the GFR is less than 15. A nice representation to the right is useful for patients to show them what percentage of normal kidney function they actually have. So when a patient does approach stage 5, we can tell them your kidneys are functioning at less than 15%. What's important to note from this slide is that as chronic kidney disease progresses, we see the symptoms of chronic kidney disease worsen. And with that, we also see a higher prevalence of depression. Next is an illustration of the psychological burden of chronic kidney disease. So a patient starts at diagnosis, at which time they have to cope with fear, anger, frustration, and sadness with this new diagnosis. And what goes hand in hand with that is a few lifestyle changes. So patients have to adjust to a new diet, new exercise, and oftentimes they have to start a lot of new medications to help treat multiple aspects of chronic kidney disease. So it can be quite burdensome. They also along the way experience complications, and they have to maintain their life roles, accepting disruption in their daily routine. And then when we arrive at end-stage renal disease, this can be a turning point for a lot of individuals, and this is the point at which they experience a major life change. More so than just the daily routine of getting to dialysis 3 times a week, they tend to confront their own mortality. I have a lot of patients say, you know, doctor, now that I'm on dialysis, if I don't ever get a transplant, I know I'm going to die soon. So that can be quite burdensome and emotionally taxing for a lot of patients. So then they start dialysis, and at that point, we can talk a little bit more about the routine, but they ensure that they're getting adequate dialysis care. And lastly, even after transplant, patients do have to experience the burden of taking immunosuppression long-term. Sometimes they experience complications, including infection. So the journey does not end at just transplant. The process goes on for a long period of time.
Dr. Kang, you mentioned a little bit about sort of the journey that a patient goes through. I'm wondering if for those of us that may not be as familiar with the nuts and bolts of dialysis, if you can sort of paint a picture for what the schedule might look like for a patient who is starting to undergo dialysis. What's this look like? What do they need to do in preparing for dialysis? What does a typical dialysis schedule look like? And sort of give us the 10,000-foot view of how this impacts a patient's life on a week-to-week basis.
Sure. So in general, most patients do have to go to dialysis about 3 times a week. For the majority of patients, usually they're dialyzing for at least 4 hours per treatment. So they're already committing a minimum of 12 hours per week to a dialysis treatment, towards their dialysis treatment. But that doesn't include the time to get to their dialysis unit. Oftentimes, a lot of our more disabled patients need transport. So there's that amount of time to take into account. And generally, they have to get there early to get weighed, to get their blood pressure taken, and to have their access cannulated. And then at the end of the treatment, they also have to hold pressure over their access for a period of time. They again have to get their blood pressure taken and then get weighed again. So, you know, all in all, the process can take sometimes a good majority of the day. So this can be, you know, quite taxing on an individual. And that's just the traveling back and forth. A lot of times patients do experience fatigue after their treatment. And oftentimes it takes them another day to recover until they have to, again, be back at dialysis the following day. So this next slide is an introduction to the facts about major depressive disorder and chronic kidney disease. I will say that we will expand on each of these topics throughout the talk, so I won't get into too much detail right now. Psychiatric disorders are common among patients with chronic kidney disease and ESRD. Depression is the most common psychiatric disorder that we see in chronic kidney disease. Depression in CKD is correlated with poorer quality of life, worse medical outcomes, and increased mortality. The reported prevalence of depression in CKD patients varies widely. So you'll see in parentheses 20 to 65%. The incidence is even higher in end-stage renal disease. The question becomes, what accounts for this wide range in terms of prevalence? And we'll, again, touch on this a little bit later, but a lot of this has to do with the methods by which we use to diagnose depression in these patients. So whether or not we approach the diagnosis of depression with conservative measures or if we use an aggressive approach. A lot of times the self-reporting tends to have a higher diagnosis rate of depression. Next, the interactions between depression and CKD are dynamic and multifactorial. And lastly, despite its high prevalence, depression in CKD is still misdiagnosed due to overlapping symptoms.